Okay, good morning, everyone. But it's good evening from Ghana because in Ghana it is 11 p.m. here. So good evening from Ghana, but good morning to everyone. I would first of all want to thank the organizers for this opportunity to do our presentation, showcase the work I've done with my team, with you all. On the call is Dr. James Antwi, the Country Director of Adventist Health Service and Adjunct Professor for Philippine Christian University. We did the work together. This morning, I am talking about compliance with privacy and confidentiality in Ghanaian public healthcare facilities. This study, if you look at the picture out there, that is the picture of a hospital in Ghana. It is called the Greater Accra Regional Hospital. This is in the city, an urban area hospital facility. The premise of which this study was carried out was that health systems actually does impact healthcare. It does impact protection of privacy and confidentiality of patient medical information. But then how did we know which of them does impact? So we went out there to do the study to find out. And during the process, this is a quote that affirmed that actually health system does impact patient privacy and confidentiality. It says, there are times when we unconsciously discuss patient in a way that relatives get to hear without patient's consent. This was a unanimous call from the focus group discussions. The background to which this study was conducted is that within our health system, within every privacy protections, even in technology, we know that privacy, confidentiality protection is a fundamental human right. This is enshrined in the Universal Declaration, Human Rights, privacy protection articles and constitutions in various countries. So it is not news. However, within the Ghanaian context, although we have the policies, we have the constitutions, we have other acts, there still is a challenge when it comes to protecting patient information and the clinical setup. So the study focused on nurses and midwives' perspective of how they go about in their duties. And in Ghana, nurses and midwives basically are the primary custodians of our health facility patient data. So why we use nurses and midwives primarily. Again, there is growing importance of privacy and confidentiality in healthcare, and this is occasioned by the increasing use of technology, of which we all know, and social media. There's also changing health behavior and health outcomes. Demand for insurance from insurance companies. There are lots of lawsuits going on, and insurance are paying high demand. And so there is the need for the privacy and confidentiality protection to be increased. In the Ghanaian context, this picture is a representation of how the society is changing, is evolving in the sphere of privacy. So up there on the left is the typical local setup of a Ghanaian community, where we have families, we have all of them living together. They eat, they share, they sleep together in rooms like this. But as time went on, we found that families no more commune like this. Families are nuclear in nature now. We find children having their independence, each person having their own room. This has not stuck to families alone. It is evolving where our health records has also been affected here. So at the top there is how medical records used to be kept in facilities. You go and it's all exposed like this. But as time went on, we are seeing that these medical records are being put on electronic machines, laptops, desktops, tablets, and other social or internet services, the cloud system. So there is more security, there is more protection when we come to privacy and confidentiality. The patient record in Ghana, this is an ideal situation. This is what we are all expecting, that if everything is working well, patient records are well protected and well secured. It promotes efficiency in how nurses work. That's workflow. Again, it supports effective and safe data-driven decision making. So you see that it's a loop. When one is working well, it ripples on the other and the system works so well. So our problem statement is that despite protocols being in existence, there is still breaches occurring in our clinical environment. And then some Ghanaian facilities have limitation in structural resources, and such as workstations, inadequate training. Again, this impacts the seamless relationship between nursing and digital record keeping. What is the gap? What is the gap here? The gap, we notice that studies have it that there is limited focus on how the overall system structure influence the compliance of patients' medical information. But how does this happen? We are not too sure. So we set out to go and find out how this happened within our Ghanaian hospital setup. We set 2 research questions or research objectives actually to go and search. First of all, the study would examine how the health system structure itself impact nursing and midwifery adherence to data privacy and confidentiality protocols. And then we also identified the specific barriers that impede the maintenance of privacy and confidentiality. The study was situated within a theoretical framework, and that is the health systems approach. We looked at the WHO 6 building blocks of the health system. And this building blocks, we have health financing, we have health information, we have leadership and governance, we have service delivery, we have health technology, health workforce. Now, these systems, they do not work in silos. So they are interconnected, they are interwoven, they work together, and a small challenge in one trickles onto the other. So there is always this ripple effect from one to the other. How does the system interplay? How does it actually work? The building blocks, they work with feedback loops and they are interdependent on each other. And so, for instance, there is interconnectedness. How will the system apply here? If we take, for example, the health workforce, which is where the staff capacity is, when there is a shortage in staff, we will see a direct effect on poor service delivery. So you go there because they are overworked, there is poor service delivery, even in the midst of high finances. Loop, feedback loop. One system feedbacks into the other. So if we take information services, if they provide quality and good data to leaders. Leaders are able to make very informed decisions. For example, what do we purchase? What kind of medications are needed? How the system is running? Proper allocation of funds to the various sectors. Holism means that the system does not work in silos. They work together. So when one part of the system is weak, the whole system begins to fail. And finally, they leverage on each other. Here, we would say that facilities, health system need to identify which of the six building blocks are we strong in? Where can we leverage? So if the strength is on leadership and governance, here the leaders then support the other system to build very well. So we bring this into the IT and technology world. The building blocks are there. Come into the field. What exactly do we then have to do? We have to ensure that there is data protection. But how do you do that? So when we have good network security, when there is access control, when there are policies and then compliance to these policies, it comes out to give us that component of data security. You will see confidentiality, you will see integrity, availability, and authentication. So all this is what has been described in the diagram I just described. This is an elaborated version of that. From this table, this is a representation of data breaches within Africa 2024 report from the Africa Data Protection Association. This is a report that came out. And this is the first 10 countries with data breaches. We look at Ghana. Ghana is highlighted ninth. And ideally, we say ninth is good. So do we even want to clap for ourselves? But it isn't good enough because there are other countries doing better. So where we are as a country on the 12th position in Africa and on 92nd position globally is not good. So as a people in Ghana, we need to set up to bring in more measures, to bring in policies to ensure that our data protection, our privacy and confidentiality, especially of patient medical information, is on point. For the methodology, this study was a purely qualitative study, so we employed vignette as a data collection tool where scenarios, real life scenarios was used for cases and nurses and midwives responded to the cases. The country was zoned into three based on resources, based on rural and urban population wise and the number of health facilities available. So each facility, each zone gave us one rural and one urban facility, having a total of 6. In all, we had 60 nurses and midwives taking part in the focus group discussion. The study, we had ethical clearance from the Ghana Health Service Ethical Review Committee, and we used thematic analysis for our analysis. So when you look at the table, it talks about the public, faith-based, rural, and urban. So each zone, we had one public, one faith-based, one rural, one urban facility being represented for fair. What were our findings? The findings of the study show weaknesses across key WHO health system building blocks in respect to governance and leadership, service delivery, health information management, and inadequate human resource in protecting patients' information. thus supporting Ghana Health Service findings in one of their reports. So we are taking them one after the other. Under leadership and governance, we notice that there is lack of explicit, well-communicated data privacy policy implementation within facilities, leading to unnecessary sanctions. Participants were not happy with this situation, and therefore they made comments like, I think this is not a correct way to address such a change. Again, under health workforce, we identify staff shortage, and this was especially in the rural areas. And there was training deficit regarding digital privacy and sometimes discussing patients in the presence of other relatives without patient's consent, which is a no-no. So within the focus group discussion, it was identified across that there were times that patients' relatives get to hear of patient information through the health workers. And this is a quote from the groups. It says, there are times when we unconsciously discuss patients in a way that relatives get to hear without their consent. Others also said, due to shortage of staff, nurses, and midwives, nurses and midwives get patients' relatives to assist them in their operation. So while assisting, some of the relatives are curious and they take patient's folder because it's paper record and it's available for them. So they go through and they get to know patient medical information without the consent of patient. When we come to health information management, we saw a lot of weaknesses here as well. So there were lack of physical file storage. There was lack of user access control on computers. And so participants here again were of the view that using folders do not help them in protecting patient medical records. And they affirmed this by saying, and I quote, the use of electronic data would greatly assist in maintaining the privacy and confidentiality of patient information. You can see clearly that information in most facilities is not well coordinated, unquote. Under service delivery, high patient volume was identified. Noisy environment, lack of private consultation space. Sometimes failure in meeting WHO standards for safe healthcare due to inadequate training, understaffing, and poor infrastructure. This is also communicated through the focus group discussion. And they said, we need to implement electronic health records to eliminate physical folders handling by relative. Increasing nurses and midwives' capacity through long-term training programs and provide immediate in-service training on ethical code and privacy protocols. So these were all concerns from the focus group discussions. Our thematic findings, we had 3 themes out of our findings. And the practicability of it was that we looked at adaptive behaviors. So here staff often, and I observed that staff often bend rules to make the system work when they are under pressure. An example included sharing login details or giving folders to patient relatives to go and purchase medications and other items. 2, we identify siloed operation. So there was lack of collaboration between IT, management, and clinical staff hinders privacy efforts. because there was no coordination. And then there was the cultural component where, because of the nature of the people, how they live, thinking that it's okay for people to know, it also hindered how privacy and confidentiality was managed. Our key drivers to breach. So the study found that weak leadership accountability mechanism leads to breaches, inadequate infrastructure and IT system leads to breaches, inadequate training for staff on confidentiality ethics, and overburdened personnel, compromising speed over ethics and security. So this is a picture of how, when all the drivers that we have looked at, if they are weak, then it means that our data protection, data privacy, confidentiality is already weak. That's why we are seeing it in red, because all the system, the blocks, the 4 blocks we identified were weak. And so data privacy was also weak. Now, the dynamics of our findings was that centralized weakened data privacy, as the picture showed. So on a whole, there was centralized weakened data privacy. And it means that there is vulnerability of patients' confidentiality due to the infrastructure and lack of interoperability, inadequate implementation of data protection laws. Under leadership and governance, we say high-level policies that, when weak or absent, fail to protect data during digital transformation. Health workforce, the human element of which is very important, where breaches occur due to lack of training. So because the staff were not trained, there were breaches here and there due to their own ignorance. Service delivery, rapid adoption of technology like electronic health record would help to expand the protection of data privacy. And then lastly, health information system. We said if there is infrastructure and it is not secured, it allows for unauthorized data manipulations and data sharing. What were our key, or what's the key message here that I want all of us to take with us? The study concludes that there are wide-ranging gaps in public health care facilities that threaten patient privacy and confidentiality. And if it is not addressed thoughtfully, it will result in data breaches. There are also clear need for robust data architecture that enables seamless, secure information sharing across different nodes to analyze trends while maintaining privacy. So as we go along, there should be secure and robust data management system. Now, one interesting thing that we found that across the levels of the nursing profession, all the nurses had an understanding of their responsibility or what privacy, protection, and confidentiality was. However, they were concerned about the other factors, other drivers that prevents them from protecting patients' confidentiality and privacy. And those were the staff shortage, and then compliance, and then reliance with paper-based record, and of course, weak leadership that was identified. So to fix this, staff recommended transitioning to electronic health record system, which is a digitization, increasing staffing level, and also providing facility level in-service training. So in conclusion, health systems are complex. It's an adaptive entity that is crucial to safeguarding patient data. And operating the health systems in silos undermines protection of patients' privacy and confidentiality. And this is seen especially in this Ghanaian context. We are also saying that weakness in governance, workforce, and infrastructure directly lead to breaches. And it is very, very clear to that. So what we recommend is leadership. We should enforce facility-wide data protection. So the leadership of the various facilities, they should ensure that there is data protection policies and not just it being available. It should be enforced. 2, workforce, regular targeted training on data privacy and ICT. 3, infrastructure. So we should have secure physical records and upgrade of electronic health record access security. Service delivery, we recommend that they should create private, quiet area for consultation. And then the policy should be adopted holistically. They should use a holistic approach when treating patient privacy and not look at it as a technology issue or an individual case. So to bring it all together, we recommended adopting the 3 levels of protection. Here, we are looking at administrative protection, technical protection, and physical protection. Administrative protection gives powers to the nursing leadership. What must they do? They must ensure that their staff comply with policies. They must even make the policies available for the staff to use. Technical protection. This involves what the nurses and midwives must know. So organizing regular in-service training and refresher courses for them to sharpen their knowledge and skills on how to protect patient data confidentiality and privacy. And lastly, physical protection. It involves what the nurses and the midwives must actually do. So what they know to what they do. They must be able to use passwords on their machines, know that when you're leaving your machine, you should turn it off, put it to sleep mode, other things. And if there isn't electronic record system, then you lock the folders or the paper records in cupboards and cabinets to prevent passerbys, to prevent other patient relatives having access accidentally to patient medical records. So on that note, I want to thank everyone for listening, and I will leave time for any question for clarifications. Thank you for listening.